Bismillah ar-Rahman ar-Rahim. Today we are going to discuss with you bone strengthening agents. So we start by discuss bone remodeling. Bone remodeling is the process of removal of old bone and replacing it with a new bone. Osteoclasts attach to the bone surface and secrete acid and enzymes that dissolve away underlying bone. So it induces bone resorption. On contrast, osteoblasts then migrate to these resorption bits and secrete steroid, which mineralized with calcium phosphate crystals, which is hydroxyapatite in its nature. There is another cell which is called osteocyte. Osteocytes serve as a mechanoreceptors that sense skeletal stress and send a signal to regulate the process of bone remodeling in areas that need renewal. So it is an orchestra between osteoblast, and osteocytes. When resorb the bone, one adhere or form calcium crystals, and the third one is a mechanoreceptor. Then we shift to what's called rank ligand, and osteoprotegrin. Rank is the abbreviation of receptor activator of nuclear factor kappa, is a specific receptor on the osteoclast. So rank is a receptor on the osteoclasts. Rank L or rank ligand located on osteoblasts and bind to rank to stimulate osteoclastic bone resorption. So rank ligand is located over the surface of osteoblasts and it binds to rank on the surface of osteoclast to induce bone resorption. So there is integrity between osteoblast and osteoclast. It is a balance. Osteoprotegrin is a soluble decoy receptor produced by osteoblast and bone marrow stromal cells. It binds to rank ligand, preventing it from binding to rank. So osteoprotegrin stimulates bone formation, whereas rank ligand stimulates bone resorption. Bone resorption is driven by rank ligand and is inhibited by osteoprotegrin. So now we shift to non-pharmacological measures. We have here vitamin D. Of course, all of us know that the source of vitamin D is coming from the effect of ultraviolet of the sun rays over the skin. So the body makes vitamin D when it is exposed to ultraviolet rays from the sun, mainly in the morning, early morning and before sunset. And the food sources of rich in vitamin D include cheese, margarine, butter, fortified milk, healthy cereals, and fatty fish. And all of us know calcium sources because vitamin D needs calcium to help its absorption and to help its deposition in the bone. All of us know that dairy product with egg and the fish are rich in calcium as well. So adequate calcium intake from 1000 to 1200 milligram per day is required for premenopausal women and men, and from 1200 to 1500 milligram per day for postmenopausal women and men equal or more than 65 years of age. Adequate vitamin D intake is average from 800 to 1200 international units per day. Regular exercise, limitation of alcohol consumption and caffeine intake, and stop cigarette smoking, fall prevention. All of this is non-pharmacological agents or non-pharmacological measures used for maximize bone in the body, which is called bone strengthening agent. So adequate calcium intake. Dairy product contain 300 milligram per cup of milk or yogurt and ounce of cheese, and a cup of calcium containing fruit juice. Low-fat dairy products are the best source of calcium supplements. Calcium supplementation should be added if insufficient dietary calcium intake. Calcium carbonate and calcium citrate are well absorbed if taken with meal. Normal calcium absorption needs gastric acid. So calcium carbonate absorption is significantly reduced in patients with achlorhydria. Citrate form is not much affected, so best prescribed if PPI is taken or history of kidney stone. Citric acid is low in urine of a stone former. So calcium carbonate or calcium citrate. Calcium carbonate is best, but in cases of achlorhydria or in cases of the PPI intake, in case of gastric troubles, gastritis, or gastric ulceration, as well as in case of history of kidney stone, calcium citrate is better used to avoid the complications that may happen from calcium carbonate. Adequate vitamin D intake. Normal serum 250, normal serum of 200, normal serum level of hydroxyvitamin D level is 30 to 100 nanogram per ml. The usual form is, in general, 1000 unit daily of vitamin D will raise the serum level by 6 to 10 nanogram per ml. Recommendation for hypovitaminoses D. This is the range, and this is the management of that range. 25 hydroxyvitamin D level from 20 to 30 nanogram per ml, requiring 2000 unit of vitamin D3 daily, while from 10 to 20 nanogram per ml needs 50,000 unit vitamin D2 weekly for 3 months, and then 2,000 unit of vitamin D3 daily. Less than 10 nanogram per ml, requiring 50,000 unit of vitamin D twice weekly for 3 months, then again 2000 unit of vitamin D3 daily. So as a maintenance, usually we use vitamin D3 in a dose of 2000 unit, while for the management 50,000 unit of vitamin D2, either weekly for 3 months in 10 to 20 nanogram per ml, or twice weekly for 3 months, same duration, if less than 10 nanogram per ml. And then the maintenance again, D3, not D2. D3, 2000 unit daily. There are two natural forms of vitamin D, cholecalciferol D3 and ergocalciferol D2. Fatty fish intake, which is contain around 400 unit vitamin D3 per diet. Fortified milk, the same amount of vitamin D3 in a cup, plus adequate daily sun exposure gives optimally 10,000 vitamin D3 per day, which is sufficient, more than enough as in the usual or in the normal individuals. Patient with malabsorption syndrome, bowel bypass surgery, and severe liver disease may require higher doses. Non-compliance is the most common reason that patients with persistently low vitamin D levels on therapy don't increase their levels. So the main cause of hypovitaminous D or failure of treatment of the patient with hypovitaminous D is non-compliance. Now we shift to the pharmacological therapy. Indications of pharmacological therapy for osteoporosis History of vertebral, hip, wrist, and humerus fragility fracture. It is from the start without doing even DEXA. T-score in DEXA, PMD, less than minus 2.5. Fracs, 10 years risk of less than, more than or equal 3% for hip fracture, or more than or equal 20% for other major osteoporosis fracture. So this is the indications of pharmacological agent for treatment of osteoporosis. History of vertebral or hip or wrist and humerus. Logs for the sites: vertebral, hip, wrist and humerus. Fragility fracture. T-score less than minus 2.5 on DEXA, and the fracs 10-year risk of more than 3 or equal 3% for hip fracture, or 20% or more for other major osteoporotic fracture, but the hip equal or more than 3%. Look for discrepancy of these figures: 3%, 20%, 3% for the hip, 20% for other major osteoporotic fracture. Hence the importance of the hip fracture. Pharmacological agents include osteoporosis medications are classified into two main categories. Anti-resorptive agents include bisphosphonate, denosumab, raloxifene, calcitonin, and estrogens. Anabolic agents only teriparatide. So all the pharmacological agent used for treatment of osteoporosis, all are anti-resorptive. The only anabolic agent is teriparatide. FDA approved pharmacological agents. This table summarizes all agent which is pharmacological or pharmacological agent used for treatment of osteoporosis. This is anti-resorptive agent by red. This is anabolic agent by red. So anti-resorptive agents include bisphosphonate and non-bisphosphonate. Hence the importance of bisphosphonate in treatment of osteoporosis as anti-resorptive agent. So bisphosphonate include alendronate, trade name is Fosamax brand, ridronate, trade name brand Actonel, tablet form, oral form, and epandronate, trade name is Boniva, or this is the brand. Zoledronic acid, which include Aclasta brand. So we have alendronate, ridronate, and epandronate. The first three oral, epandronate intravenous. So alendronate Fosamax oral, 10 and 70 milligram daily and weekly. Daily for 10 milligram tablet, 70 milligram weekly. Ridronate or Actonel oral, we have three concentration: 5, 35, and 150 milligram daily, weekly, and monthly. Epandronate or Boniva oral, 150, like the monthly use of ridronate, so 150 milligram and also monthly. And we have another preparation of epandronate which is intravenous, includes 3 milligram every 3 months. While zoledronic acid or Aclasta is only intravenous, 5 milligram and used yearly. So zoledronic acid or Aclasta, 5 milligram intravenous yearly, while Boniva intravenous use is 3 milligram every 3 months, and the others are oral preparation. Non-bisphosphonate, we are still in the anti-resorptive agent. We classify them into bisphosphonate and the non-bisphosphonate. Non-bisphosphonate include denosumab, trade name brand Prolia, raloxifene, trade name brand Evista, and the calcitonin, trade name brand is Myocalcic. Denosumab, Prolia, biologic agent, is given as is introduced in the market like subcutaneous injection of 60 milligram every 6 months. Raloxifene Evista oral, also 60 milligram daily. Calcitonin or myocalcic. We have two forms, nasal and subcutaneous injection. Nasal buffs, 200 unit per buff, and it is used daily. 100 unit subcutaneous injection also daily. Estrogen preparation or estrogen therapy, you have different preparation and regime, and we'll discuss it later on. While the only anabolic agent is teriparatide or PTH 40, the trade name brand. It is given as subcutaneous pen. This pen include 20 milligram, 20 microgram daily. This 20 microgram is given per pen per injection. It's given daily. This pen include 28 injections. So daily gives 20 microgram. It's given subcutaneously. So we start by anti-resorptive agent. We go through all of them. This simple figure explain how the anti-resorptive agent work. It prevents bone resorption in a short. We start by bisphosphonate. Mechanism of action of bisphosphonate. Bisphosphonate after absorption adsorb to bone. Act on osteoclast by binding and blocking intracellular enzyme FPPS. Inhibition of FPPS suppress formation of two important metabolites that are essential for connecting a small protein particle to a cell membrane. This interferes with lipid modification of osteoclast cell membrane that is required for maintaining the ruffled border of osteoclast. This results in osteoclast apoptosis, causing significant reduction in bone resorption without affecting bone formation. So there's a different forms of bisphosphonate. This is risedronate at Leva. This is generic. This is Fosamax. This is Actonil, 150 milligram every month. This is Boniva, ibandronate tablet, 150 milligram, taken once monthly. And this is Aclasta, which is here reclassed, which is also trade name of generic, 5 milligram per 100 milli solution, given over 1 hour. And hence the action of bisphosphonate. This bisphosphonate finally leads to osteoclast apoptosis by inhibition of osteoclast function. So apoptosis inhibits the osteoclast function, and we see the mechanism before. This also gives chance for osteoclast for ongoing bone formation. As a result, bone formation exceeds resorption and the bone mass increases. After 2 years, bone formation decline to the level of resorption and the bone mass stabilize. This results in increase in bone mass and relative risk reduction of incident fracture for both vertebral and hip level. Zoledronic acid may be the most effective as of its anti-resorptive potency, intravenous administration, and compliance. Pharmacokinetic and how to use. Bisphosphonate are analogous of pyrophosphate and they bind to bone. They adsorb to the bone. They have very poor intestinal absorption. Intestinal absorption is inhibited by foods. So it is taken on empty stomach. Main side effect is esophagitis and GIT upset. Should be taken each morning in oral preparation on empty stomach with a full water glass, and the patient should be kept in upright position and take nothing by mouth for at least 30 to 60 minutes. Hence it's difficult in compliance. So as mentioned before, intravenous forms jumps all of these precautions. Adsorbed bisphosphonate goes via bloodstream to bone, and the half-life in the bone is around 10 years. So it adsorbs to the bone and prevent the action of osteoclast and give a chance for osteoblast to form bone. So precautions: oral bisphosphonate are contraindicated in patients with esophageal problems, malabsorption, or inability to sit upright. These are indications for intravenous administration. Creatinine clearance. Oral preparations are contraindicated if creatinine clearance less than 30 ml per minute and intravenous preparation less than 35 ml per minute. Avoid using any concomitant drug affecting renal function in stage 3 kidney disease with creatinine clearance 35 to 40 ml per minute. Well hydrated and slow rate of intravenous infusion. 15 minutes for ibandronate and 60 minutes for zoledronic acid. All invasive dental work should be performed before starting bisphosphonate to lessen fracture risk of jaw osteonecrosis, because jaw osteonecrosis is a common, frequent complications of prolonged use of bisphosphonate. Make sure that 25-hydroxyvitamin D3 is more than 20 nanogram per ml before starting therapy. Intravenous bisphosphonate causes a flu-like illness and the bone pain lasting up to 2 to 3 days in around 10% of ibandronate and 30% of zoledronic acid. And the pre-medications with acetaminophen will lessen these symptoms, and you should warrant the patient for these frequent complications. Cases of premenopausal primary osteoporosis who are on bisphosphonate, it is contraindicated, considered as a class X, for pregnancy and lactation. Zoledronate is safest to be taken for future pregnancy plan and also should be stopped 6 months before getting pregnant. Jaw osteonecrosis and bisphosphonate. Osteonecrosis of jaw, ONJ, occurs in 10% of the patient with intravenous bisphosphonate therapy for multiple myeloma or bone metastasis undergoing invasive dental procedures. Good oral hygiene and good dental care are best preventive measures. Temporary stopping of bisphosphonate for invasive dental procedures 3 months earlier is good practice to prevent osteonecrosis of the jaw. Atypical femoral fractures and bisphosphonates. Atypical femoral fractures have been reported in some patients on long-term bisphosphonate therapy more than 5 years duration. So it should be what's called drug holiday after 5 years of oral preparations. Any patient with unexplained thigh pain should be evaluated with radiograph for bilateral paired peak on the lateral aspect of the femoral shaft indicating stress fractures. Risk increased in active patients, those on steroids, and those with low bone turnover markers. Recommendations 1 to 2 years holiday after 5 years duration of oral bisphosphonate and a switch to an anabolic or other non-bisphosphonate therapy. After 3 years of zoledronic acid, which is taken yearly, treatment should be stopped for the next 3 years. Then we shift to another measure of the anti-resorptive agent, which is hormonal replacement therapy, HRT. HRT versus estrogen, ERT, was used as a preventive measures against osteoporosis. Reports regarding breast cancer risk and cardiovascular events limits use of this agent to postmenopausal hot flushes for up to 3 years. We have selective estrogen receptor modulator, SERM. SERMs are agents that function as estrogen agonist in the bone and antagonist in the breast. So it abolishes the chance for cancer breast. Raloxifene, Evista, trade name, brand, is a SERM that has been shown to improve bone mass and reduce spine fracture. It is FDA approved for treatment of postmenopausal osteoporosis, and it reduces the risk of breast cancer. Dose is 60 milligram per day, tablet form. This is Evista tablet form, 60 milligram, which is used as aloxafen. Side effects: hot flushes, leg cramps, increased risk of thromboembolic disease, mainly in smokers. It increases BMD by 3% in both spine and hip, reduces relative risk of vertebral fracture by around 31 to 49%. Best candidate for aloxafen is an osteoporosis patient with a personal or family history of cancer breast. So if you have a patient with personal history or family history of cancer breast, the best candidate is for aloxafen, because it decreases bone resorption, because it is anti-resorptive agent, and at the same time it reduces the risk for cancer breast. Safe to be used in a patient with osteoporosis with a chronic kidney disease. So in a patient with chronic kidney disease, SERM is safe medication. Calcitonin or mycalcic. This is the nasal buff form. Calcitonin, salmon nasal spray, 200 international unit. Mycalcic nasal, it include 20 unit, and it contains 20 buff, 200 buff and 200 international unit. Calcitonin is a naturally occurring peptide which acts via specified receptors, so strongly inhibit osteoclast function. It is also anti-resorptive agent, has been used in the treatment of osteoporosis for many years. Calcitonin was administered as a parenteral injection, but the intranasal formulation is now the most widely used because of its improved tolerability. Salmon calcitonin is the most widely used for of the calcitonins effective in humans. It has 40 times the affinity for osteoclast as human calcitonin and is very effective at inhibiting bone resorption. The salmon calcitonin nasal spray is both convenient and free from significant side effects. Generally, the only problems experienced by patients are nasal irritations. Calcitonin has been demonstrated to be clinically useful in improving pain, not only from the acute vertebral fractures of osteoporosis, but also in Paget's disease, bone malignancies, and other sources of musculoskeletal pain, and hence its usage recently for treatment of these conditions rather than treatment of osteoporosis. Its use for treatment of osteoporosis, by other words, have been declined. On the other hand, its use in treatment of pains from malignancies, from other source of musculoskeletal pain, from Paget disease, has been maximized. Dosage: recommended dose of mycalcin injection or mycalcic injection, so for treatment of postmenopausal osteoporosis in women greater than 5 years postmenopausal is 100 international unit per day, administered subcutaneously or intramuscularly. The recommended dose of mycalcic or mycalcin nasal spray is 1 spray, 200 international unit per day, administered intranasally, alternating nostril daily. It's called mycalcic, but some countries it is mycalcin, so don't worry about C and N. Mycalcic or mycalcin, it is mycalcic trade name, it is calcitonin as a scientific name. So don't worry about mycalcin and mycalcic, the same. Side effects: Common side effect: diarrhea, gastritis, tiredness, arthralgia, myalgia, dizziness, headache, taste disorders. Uncommon side effect: hypertension, flu-like symptoms, injection site reaction, skin rash, itching, disturbed vision, allergic reactions. We shift to denosumab or Prolia, which is biologic agent used as anti-resorbative for treatment of osteoporosis. It is monoclonal antibody diet against rank ligand. You remember rank ligand. This interfere with the ability of osteoblast to bind to rank on the surface of osteoclast. So rank ligand inhibited by this monoclonal antibody, and this stimulate osteoclastic bone resorption. So again, it is monoclonal antibody direct against rank ligand, and this interfere with the ability of osteoblast to bind to rank and stimulate osteoclastic bone resorption. So this inhibit osteoclastic bone resorption because no more rank ligand. Dose is 60 milligram subcutaneous every 6 months. So 60 milligram subcutaneous every 6 months. It is already prepared injection or ampoule or syringe. Safe drug apart from increased risk of infection, as rank ligand is on T helper cells. So it is a safe drug, but increased risk of infection is around. ليه؟ لأنه rank ligand is on the surface of also T helper cells. So there is a suppression of T helper cells. So there is increased susceptibility for infection. Estimated reduction risk fracture at hip is around of 40%, and the spine is around of 70%. This is in one trial. Used safely in osteoporotic patient with stage 4 renal disease with creatinine clearance 50 to 30 milli per minute, as it is cleared via reticuloendothelial system. Such patient should be calcium supplied to avoid risk of hypocalcemia. So Prolia or denosumab is safe in stage 4 renal disease. And if you remember, CERN is also safe drug used in cases of chronic kidney disease patient. We now go through anabolic agents, which is only PTH or teriparatide or Forteo, peach hormone. Persistently elevated PTH and primary hyperparathyroidism produce or promote osteoclast bone resorption and bone loss. In contrast, intermittent daily pulses of exogenous PTH stimulates osteoblast differentiation, proliferation, and survival, results in osteoid formation and increased bone mass. So, intermittent daily doses or daily pulses of exogenous PTH act versus to the persistent elevated PTH level, which sometimes happens in primary hyperparathyroidism. So the mechanism of action is pulses, daily doses of exogenous PTH stimulate osteoclast action. It also decreases the production of bone inhibiting protein, sclerostin, from osteocytes. Teriparatide or Forteo is 34 amino acid fragment of PTH. It activates PTH receptor on osteoblast. It is self-administered on a daily basis of 20 micrograms subcutaneous for 18 to 24 months, so not more than 2 years, and this is from one half and 2 years in duration of its usage. Self-administered via pen. It is already in the market in the form of pen. Side effect: headache, nausea, arthralgia, and flushing. This is a pen of Forteo, 20 microgram per injection, and it's sufficient for 28 days. Precautions of teriparatide: contraindicate in patient with osteosarcoma, Paget disease, unexplained elevation of alkaline phosphatase, skeletal metastasis, multiple myeloma in young adult with open epiphysis, implant radiation therapy, cause hypercalcemia and calciuria. As per its cost, it is preserved for highest risk of osteoporotic fracture with a T-score more than minus 2.5 up to minus 3 with history of fragility fracture, or T-score less than minus or equal minus 3 from the start without fracture, or patient who developed fragility fracture on oral bisphosphonate. I mean failure of the usage of or failure of the action of bisphosphonate. يبقى البيشنت with failure to oral bisphosphonate or highest risk for osteoporotic fracture، وعرفناها بأنه التسكور less than minus 2.5 with a history of fragility fracture, or to score from the start more than, less than, or equal to minus 3 without history of fragility fracture. It can heal stress fractures or non-union fracture and osteonecrosis of the jaw. Not used with anti-resorptive agent, fearing of blunting its anabolic effects. PTH level should be checked before its use. If elevated, should be corrected to normalize pH level, like what happened in vitamin D deficiency. Can be used in a patient with severe kidney disease. So there's another agent which can be used in the chronic or in severe kidney disease. So we have CERN, Evista, we have Borrelia dinosumab, and we have also PTH40. After finished period of its use, an anti-resorptive agent should be used to preserve gain in bone mass. So we have mentioned that Fortium or teriparatide not more than 2 years of its usage. After it's finished these 2 years, we have to use anti-resorptive agent to avoid deterioration in the bone gain which happened. Now we shift to what's called algorithm for osteoporosis management. Adequate calcium and vitamin D intake and regular exercise. If fragility fracture happen, start medication with bisphosphonate, teriparatide, dinosumab. Do baseline densitometry and repeat it 1-2 years later. If no fragility fracture, put in postmenopausal women plus 1 risk factor, age more than 65 versus men over 70 with high risk medications. Do bone densitometry. T-score if more than -1, repeat DEXA after 5 to 10 years. T-score from -1 to -2.4, do FRAX 10-year fracture risk. Hip fracture more than or equal 3%, and the major osteoporotic fracture more than or equal 20 other sites. If yes, start medication bisphosphonates, CERN. If no, repeat DEXA 2 years later. T-score less than or equal 2.5, start medication directly, bisphosphonate, teriparatide, dinosumab, CERN, and repeat DEXA 1 to 2 years. This is the algorithm for treatment of osteoporosis before the age of 50 and age of 50, more than 65 years with osteoporotic fracture after the age of 50, and you go through the algorithm. Age before 50, avoid fracture risk with dietary enforcement, with no PMD unless with risk factors. Don't do BMD except with risk factor. Age of 50 menopause or 65 women, and age of 50 to 70 in men. No risk factor or low risk from FRAX without BMD. Don't do BMD. No BMD, just regular follow up and re-evaluation. If more than or equal one risk factor, or equal or more than moderate risk from FRAX without doing BMD, do BMD and calculate FRAX. If low risk, regular follow up and re-evaluation. If high risk from FRAX as well as osteoporotic fracture after the age of 50, this is high risk from FRAX, fall prevention, education, medications, re-evaluation, specialist referral. And also for equal or 60 or more than 65 for women and more than 70 years for men, BMD do BMD and calculate FRAX, and we go the same algorithm. Combination versus single agents. Question: not much benefit gained from two agent combinations. Harmful effect of over suppression of bone resorption is a major concern. Only in drug naive patient, combination of teriparatide with zoledronic acid show encouraging results. So only in naive patient is the only allowed combination. Teriparatide with zoledronic acid show encouraging result. Sequential use is much better than concurrent use. Monitoring response to osteoporosis therapy. In osteoporosis patient, BMD is most often repeated 2 years of treatment. Total hip BMD is the most accurate site to follow. The least significant change, which is precision estimate that informs the user about the minimum BMD change that should be considered significant. It is website calculated. So LSC, minimum change, BMD change that could be considered significant. And as mentioned, it is website calculated. BMD interpretation in response to therapy. This BMD change, this interpretation, this is the recommended action. Increase or equal LSC, means good response, so continue therapy. No change of LSC, adequate response, and also continue therapy. Decreased LSC, treatment failure means treatment failure, and in that condition, evaluate, consider therapy change. Bone biomarkers and bone remodeling. Elevation of bone resorption biomarkers predict future bone loss. A 30% reduction of these biomarkers after therapy initiation significantly increased bone mass. Marked lab variability in biomarker measurement limits the utility of this tool. So it is not much popular for the judgment of the effect of anti-resorptive agent or the bone forming agent. This is a bone biomarkers for bone formation, and this bone resorption. Biomarker for bone formation is serum alkaline phosphatase and the serum osteocalcium, while bone resorption agent is urine or serum N telopeptides and the serum C telopeptides. BMD failed during therapy. Causes and management. Causes: non-adherence, encourage adherence. Calcium deficiency, treated by adequate calcium intake. Vitamin D deficiency, treated by adequate vitamin D intake. Secondary bone loss, treat the cause. Treatment failure, change medications. Finally, we go through glucocorticoid-induced osteoporosis. Hint about it. Bisphosphonate and teriparatide have been shown to improve BMD and reduce fractures in glucocorticoid-treated patients. So the best usage for glucocorticoid-treated patient is bisphosphonate and teriparatide. I mean 40. They are instituted based on FRAX risk assessment score, T-score, history of vegetative fracture, and the patient age. To the same measures used for judgment for osteoporosis: FRAX, T-score, history of vegetative fracture, and the patient age. Thank you very much.